everyone. Welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to talk about what matters most to you, to explore new ideas, and to learn together. I'm Leah Whitehead. I am the proud mom of a preemie and a former journalist, and I'm happy to be your host today from snowy Halifax. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation. It's also very well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, visit their website at canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who want to see our little babies thrive. Today's session is live, so please bring your voice to the table. Leave comments and questions in the chat, and we'll try to address them during the program. It is through rich conversations like these where we can advance practice and learn together. So please participate and let us know where you're watching from today. Now on to today's topic, something that I think both families and healthcare professionals struggle with: antenatal consultations. What do expectant parents want to hear as they're awaiting a preterm birth? As a mom myself who did 8 weeks of bed rest and had the antenatal consult, it can be a rough experience. And so we're going to be joined shortly by Dr. Eugene Ng, and he's going to talk about these antenatal consultations, specifically when you know your baby will be born prematurely, with an emphasis on the impending birth and the extremes of viability. And these are conversations that have changed greatly over the past number of years. So it will be interesting to hear and speak with Dr. Ng. Dr. Ng is a neonatologist and chief of newborn and developmental pediatrics at Sunnybrook Health Sciences Center in Toronto. He's also an associate scientist at the Sunnybrook Research Institute, and he's especially interested in respiratory physiology, systematic review and knowledge translation, and quality improvement. He's a strong supporter of family integrated care, and we are so pleased to be joined by him today. Welcome, Eugene.
Thank you, Leah. It's nice to be here, and thanks for inviting me.
I'm going to put your presentation up here, and you can get right to it.
Okay, thanks very much, and thanks for the introduction. And you're right, this is an often very important area that we could frankly do better. And things have evolved over many years in terms of how we conduct antenatal consultations. And for those of you who may not have the experience of it, antenatal counseling or consultations are basically a session between usually the neonatologist and expectant parents to talk about the potential for having a preterm birth. And some of the more difficult conversations circles around, especially in cases when there are extremes of viability, when there are some perception of decision-making process going on in terms of whether we will or will not provide intensive care for the extreme premature babies, or we will just simply provide comfort care. So I'm just gonna, in a very short period of time, go over some of the idea about what parents really want to hear and how we could improve the way that we conduct these meetings. So first of all, we need to build a framework of these kinds of consultation. We should understand as healthcare professional that these conversation has huge impact on the family for decades from the conversation that's happened, and families do hang on to every word we say. So we should never take this very lightly. These conversation had evolved from a pure information sharing session to some of that mutual understanding of where everyone comes from to come up with what we call a shared decision making. So the framework of that is, a complicated one, and we probably should learn a little bit from experiences of people who have done it for many years, and especially from parents who had received some of these consultations to learn from what exactly do they want to hear, and certainly guided by certain principles that are listed in some of the position statements, such as those from the Canadian Pediatric Society. And now, I mean, this is very crude, and it goes back to, the years when I was a fellow being trained as a neonatologist. And the day that I stepped into the NICU, was given a piece of paper like this to tell people what the survival rates are for gestational ages. And that is the premise of the entire consultation. So, obviously, we have changed a lot, and we've learned a lot from literature, evidence, and from a discussion from ethicists talking about how we should be conducting these meetings. So really, we've been doing away with these kinds of statistics and these kinds of manner of conducting the consultation. And one of the reason for that is because gestational age has never really been shown to be a reliable predictor of long-term outcome, especially before 26 weeks. And there are also many other aspects of neonatal care that would drive the outcome of an infant, and also the perspective of parents or families, especially in terms of what this mean by adverse outcome. It's also come into question. And survival rates also vary widely in the reported literature and in different centers. So just using gestational age obviously does not work. And so to build a model for antenatal consultation, we are encouraged to explore the patient's or the family's lived experience and really try to engage in building a trusting relationship. And so we have and trying to move away from this very simplistic approach of providing standardized, homogeneous medical information. And because truly this is not all that the parents wants to hear. And really try to and also empower the families to raise issues that are important to them based on their own experience, based on their own living circumstances, based on their own relationship, with each other. And so it really is to build a mutual understanding of each other so that we can come up with the best approach together in terms of how we should manage the baby. Now, never underestimating that these are extremely difficult circumstances and meetings, and often there are difficult decisions to be made because of the uncertainty of the prognosis in each case, regardless of gestational age. And so the management decision can really vary widely from case to case, depends on many of these circumstances. And so while there are some guideline as to how we should approach these babies, especially at the borderline of viability ages, somewhere between 22 to 25 weeks, there really is no accepted agreement on how we should be managing these babies. And, it's also very important to remember that no matter what happened, most birth would involve an opportunity for a family to welcome a child into the world, even though one may not live for very long, or maybe one was born extremely prematurely and had a long road to go. So we have to have some guiding principles. And, obviously underlying all of that is to determine what is in the best interest of the unborn child. And for the physicians or the healthcare provider, our job is to provide the best medical evidence on the probability of survival and morbidities to provide the family with some baseline information to help make a shared decision. And for the parents, they will contribute by insights on what they are hoping for, what their spiritual values, and how they interpret the information given by the health provider and their desired involvement in decision making. So it is a very complicated process, and oftentimes it will take more than one conversation to come up with something that everyone is comfortable with. Now, it's very important to understand the parent's perspective in these conversations. So, there are many studies that are published talking to mothers and fathers or both to see how they feel about these experiences and what exactly did we do right or what could we do better. Now, most felt that the consultation was a positive experience, but in terms of discussion on data and outcome, um, although most people find it important to do so, there are a certain number of people who felt there are too much information given. And obviously, when we have these conversations, many a times we go up to the ward and speak to the mother by herself. And obviously, it's more ideal if we can speak to both parents at the same time. And most wanted to discuss about, addressing their concern. But instead of talking about outcome, more importantly, is important to emphasize the role of parents in the NICU for preterm infants and how to integrate themselves in the baby's care in the NICU, and also to better understand the NICU environment, and then sometimes including a physical or virtual tour of the unit, just to give an idea. So, and Katerina Staub had written an elegant article in 2014 talking about what parents wants to hear. And, instead of always being negative or being realistic about data, talking about outcomes, talking about risk of mortality, it is also important for us to instill some hope, because all cases involve hope. And, we don't want to be in a conversation where we do not address that possibility. And they do also want reassurance, first of all, that they have not done anything to cause the preterm birth, and that we have to address that each family and the fetus are unique, and that all of the factors had been considered. It's very important to acknowledge that a baby is a baby. It's not just a gestational age. And so, information that we provide need to be balanced, value neutral, and very important to be honest about what we say. And of course, parents had also give some advice to neonatologists as to how do we conduct these meetings. And I think it's important to learn from that little gestures about, not sort of in a feeling in a position of authority, so people should sit down and really listen to the concerns, so that the meeting is not mutual. It's not sort of the doctor giving parents information, but really is a meeting that creates an understanding between each other. It's important to be prepared, even though you may not give up all the potential information. It is important to be prepared so that the parents could ask the questions and the doctors will be there ready to answer the question. And obviously, the amount of information given is often tailored to what the parents wishes to know, and also important to be compassionate, but yet at the same time be realistic, and don't rush. And if someone has a list of how much you need to cover, you covered what you need to, and you can always go back and talk more. And remember that these are very stressful situations. Most parents are not going to be able to grasp or to retain a huge amount of information. So it is important not only to not use medical jargon, to make sure that every point is understood, and definitely don't rush. Many of these meetings are conducted over days, and sometimes we go back and we talk about the same questions again and address the same question again. So it's important because we have to understand how important these meetings are for the families. And offering a tour to the NICU is often helpful and is often proposed. And obviously, because of patient confidentiality, or because of now with infection control, oftentimes a physical tour is not possible. In our center, we have created what we call a lookbook, where there are pictures of the unit and pictures of babies, pictures of parents providing care, such as kangaroo care, that we use as a visual aid to help guide parents to have a look at what the NICU looks like without physically being there. And so those kinds of things are quite helpful. And finally, I'd just like to hear, what parents feel. And so this is a Wordle that is created by one of our veteran parents, and having talked to a whole bunch of different parents, there are many of these themes that came up about how they feel about having the consultation or having the prospect of a preterm babies. And you can kind of see that in the overwhelming majority of people, that there are not great feelings. They feel terrified, they feel afraid, they feel sad, they feel alone, confused. So it is important for us also to instill some of the other things that is said here about optimism, about hope, and so on. So I think it is very important not only to provide this information to parents, but also to really understand how they feel and address how they truly feel. So the grand challenge for the medical team is really to think about how do we, in this short time frame, provided this information. And so obviously, as I said, don't rush, but sometimes we don't have time. And so under time constraints, we do have to do the best we can, focusing on what's the best practice are, and really share the information and consider, yes, we do this day in and day out, but for every family, these are unique situations and they are important. And so to understand it, that, for the family, really, it is one of the worst days of their life, at least potentially speaking. And so, we do need time to understand where they're coming from, and they need time to understand, what we're trying to say to them. And of course, we cannot do it as if this is a, here you take a book and this is exactly what's going to happen to your baby, because understanding that every baby is different, every family is different. And so the challenge for us, of course, is that we want to build that trust, but sometimes there's just no time to build relationship. So, we do the best we can, but obviously if you have time to go back again and again, just to create an understanding. Obviously a conversation that really requires clarity. But unfortunately, as I said, there are so many limitations for what we understand, and each case is different. So we do have to acknowledge that there are a whole piece of unknown for each case that we just don't know about. So to build a gap, I think, it's important to really to prioritize the consult, and so that the person who is doing the consult will have dedicated time, spend the time we can, and given the different priorities we have in the unit to take care of patients, these are important to have dedicated, uninterrupted time. And if we can leave behind some materials or find some other resources for the families to talk to, and we have even suggested that maybe some veteran parents can go in and speak to the parents again after the fact and make sure that they understand their perspective after a conversation with the physician. And obviously, it needs time for reflection and for for them to digest the information before you go back in again. And so sometimes we do, if we have the time to wait a day or two, and then we'll go back, and so that they have time to really simmer down and understand the what's being said, and then they may have more questions, or maybe they have more answers, or maybe their thinking may be different, or maybe the decision will change. And so it is very important for us to make sure we take the time, and as I said, to engage grad parents for peer support. And so these are, in a nutshell, a very short snapshot of what we think an antenatal consult should be. And I really do welcome some comments from people or some questions. Yeah, sorry that we don't have a lot of time to talk about this very complicated topic. You're muted, Leah.
Thank you. I was saying thank you so much for that presentation. All the things that you addressed in your presentation were questions I was scrolling down of things that, it's so hard to consider when you say that physicians need to take time for this. But like you said, you're under a time constraint most of the time. And so I read your bullet there and heard you talking about prioritizing the consults, and how does this actually look? Do you think maybe does it have to be all on the neonatologist? What's the way forward that someone can spend time?
Well, I mean, I guess, we work as a team, and so it is important for us to understand that, these things takes time. And, I think, my own experience many years ago when obstetrician grabbed me by the throat to go speak to a parent at 2 a.m. because she's about to have a 24-weeker. And so you feel very uncomfortable having to do this. But obviously, if that's the situation, then you have to also tailor the conversation to be a little bit more concise. But obviously, we also know that in the majority of cases is really not that big of a rush, and so it's kind of it's the etiquette of how we do this. And what I was saying about is we have so many competing priorities. And I think, let's just say if we ask a particular professional to go speak to a mom, and so we couldn't say, okay, well, you got 5 minutes before you had to do this procedure, so can you go and speak to her? So I think that would be the wrong approach. And so we have to understand that we really do need to have the ability to take protected time to do it. And that's what I meant. So, and obviously when we do this, we have to make sure that, let's just say, the pages don't go off, or that people don't find you, that you will have someone else to cover for you when you do this. And so I think it is actually important. And sometimes it's just a matter of how you see this as how important do you see this as part of your workflow. And so we would say, okay, let's make sure that we have at least half an hour, if not more, especially when we go talk to a mom who is at 22 weeks, for example. And sometimes we go up there and seeing a mom is there by herself, and so she said, oh, my husband would really like to come, and can you wait? And so if you're too busy, some people will say, well, but I have to talk to you now because otherwise I won't have time. But that is not acceptable. And you can say, okay, let's just make sure that when everybody's here, then we go sit down and talk. And also it's very important about the mannerism, and I kind of mentioned it a bit, because people like to stand up, hands crossed, talk and talk to parents like I'm telling you this is what happened. I think the simple gesture, and I think it's written in one of the paper, about just sitting down and be at the same eye level, and don't make people think that you're in a rush to leave, and it just really start a conversation, and don't go right into this is what happened to your baby in half an hour's time. This is we'll go sit down and see how they feel, how was the day, introduce yourselves, and really try to understand where they're coming from. And sometimes actually that first there's a calming effect for that, but also it'll give people the sense that you are really here to hear them, to listen to them, and then you give your perspective, and then you want to have a mutual conversation. So I think these are important, and sometimes it's a little gesture, right? But we really should not rush into these. But and I think I sort of realized it early in my career of how important this is.
We have a great question here from Laura Webster. She says, I struggle between giving too much info, but feeling like I left information unshared, or leaving the parents unprepared. How do you balance that?
Very, very good question. I think we've all learned. I think as a person is more junior, they also kind of feel that, well, there's a list here that I must go through. Respiratory management, all the potential complication of a baby in the NICU. You talk about ultrasound, talk about echo, talk about hemorrhages, infection, and everything else. So you can, and we've heard it loud and clear from parents that they do want some information, but if you give too much information, then it's just going to go somewhere else, because it's frankly a bit too overwhelming to absorb all the information. And so I think some people may have pamphlets to talk about some conditions, but overall you're going to have to understand what they really want to know. Like I think, before you have a baby, when all their minds are thinking about at the delivery room, for example, then talking about necrotizing enterocolitis, which may or may not happen, not right away, is kind of moot, because I think they don't need to know everything that you need to know from the NICU right away. Because remember that education or learning, getting knowledge about babies will continue over time as they spend time in the NICU. And you as a parent, you probably understand that you would not know all the details, but by 2 months into it, you know what the alarm is like, you know what a saturation means, you know what a heart rate is, what's the spell, and then it starts to come. So I think you're right. Sometimes you do need to give some amount of information, but I do feel that as I have gained more experience as a physician, I feel that I am okay leaving out information, because you just need to get down to what is being retained. And if you think that you give them a whole mile list of information, they're only going to retain the first, 2 or 3. Well, then you don't. I don't think that you need to use all that time.
We have another great question here from Fabiana. Do you think the clinicians' views on disability influence the way they consult parents on the verge of delivering early? I often hear, "I'm sorry for my son's cerebral palsy, as it was a bad outcome. For me, it was a great outcome. After all, I brought him home." I'd love to hear your thoughts, as the viability age is lower, as the chance of having a baby having a disability is higher.
Yeah, it's a very insightful question, Fabiana, and of course I'm prepared for this. I think I didn't have all the time to explain it, but there was a lot of changes in terms of how we counsel because of this whole concept. We understand, and I think I kind of alluded to it earlier, to say that I think the concept of outcome is very individual, and I think people had the concept about what is an adverse outcome, and they kind of keep using that as a way to counsel about, okay, I need to give you information about how bad things can be. But I think we've learned, and I've learned from especially my colleague Paige Church, who had talked about this topic very eloquently, about what is the concept of disability. And so I think and that is the reason why having a conversation with them to try to understand where parents come from is important. I think we really need to do away with these kinds of connotations, because you're right. A child is a child, and so everyone can have challenges, and so there's no such thing as a good or a bad outcome. It's kind of important to emphasize that, and so I do think that we need to get away with these kinds of notions about what is a bad outcome. So you're right, and I think to understand the perspective of the parents and to say how they view these kind of challenges is kind of important as well. So yes, I totally agree with you, Fabiana, that the concept of a bad outcome is no longer relevant.
I can't help but think about that page you put up at the beginning of your presentation that was showing just that, the viability, the percentage based on gestational age. And I'm just wondering how that affected you as a physician, especially when you're first starting out. And I don't know if you would still experience this now or not, but how much do your emotions play into the whole consultations?
I mean, we try to be as objective as we can, and I think it's important about personal biases, and obviously, we really shouldn't. There are, first of all, these statistics are very crude, and I guess I was showing that piece of paper because that was exactly what's given to me with very little training when we started out, to say that this is how you talk to families. And so some years later, I sort of realized that, well, this is not the way it should be, and it is not that simple. And I think people, we really probably should train our trainees in a sort of, and I think we are, in sort of a more sensitive way of providing these consultation, because for many people this is still being seen as a data sharing exercise, which I think it is far from the truth. And over the years I have actually done away without giving data unless it's really really being asked, because I actually think
Wow.
that babies are not statistics, and each baby is different. So while you can comment on in general from a network data what a 23-weeker will do, it doesn't really apply to a particular baby at 23 weeks because of these other things that we've mentioned about. So so first, I think you can give a general idea when if people really want to know, and in some way it could help guide you as part of that decision making. But to put it as an emphasis may not be right anymore. Now, in terms of your question about how does your personal emotions play into this, I think you cannot help it, but to use a little bit of your personal experience, and maybe for me who had never experienced a preterm birth myself as a parent, you can really only use your own experience as a neonatologist to talk about this. Um, you know, and I still try not to use my personal bias, because I think it's more important to understand where the families are coming from, and then you can sort of use your own experience to guide a little bit, to guide them a little bit. And so, I think it is difficult if people have, especially if people have problems with I just say the edge of viability, and how far we go. uh, you still shouldn't be using that as your, because you could create a very biased conversation. And what I've learned over the years is how easy you can steer a conversation based on your own bias. And so it is actually a challenge for us to try to be impartial to how you feel about, let's just say, 22 weeker. And I keep using 22 weekers because I think at this current age right now, that is probably where the biggest discussion is, in terms of how people feel a certain way.
When you walk away from one of these antenatal consultations, when does it feel successful for you? When do you feel like, okay, that went well? What are kind of the guideposts for you?
Um, that's a good question. I mean, I guess I don't really think of anything as sort of a didn't go very well, and as long as you have an expectation of what it's going to be, I think as long as uh, the family has come up with some decision that are um, that they're comfortable, or that we are all comfortable with, then I think the job is done well. And I think as long as we understand that after one conversation there may not be a decision made, and it's also very important, and if I didn't say it enough, that families should know that they are not alone in making decisions. And making decision is not an absolute in these cases, also because we sometimes obstetrician will kind of say that, well, what is that decision? And sometimes there is no decision, and you don't want to put it that way, to go into a room and say that by the time we come out, you got to have to light the white smoke, you have to have a decision made, because it's not always that case. What we're trying to do, and so it goes back all the way to the beginning of the slide, to say, what are we trying to achieve in these conversations? Is that the bottom line, the framework is really to create an understanding. And so even if we cannot make a firm decision at the end, I think you shouldn't feel that you haven't done your job, because I think as long as we understand our role is to provide the information, but also to 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 hopefully help them, to help the family come up with some sort of decision that everyone is comfortable with, given the information that we provide and they provide. So in a way, it's a very dynamic thing. And so I most of the time, if we do that, and then I feel that we've done our job right. I just, if I have time, just to relate a story. I was, a new staff, and I was in some sort of event, a fundraising event for the hospital. And at the end of the day, someone tapped my shoulder and asked if I remember her. And I said, kind of. And so it was, one of the parents, and I don't want to name her name now, but you all know her. She was sort of telling me about the conversation that we had that I frankly did not remember, of how I've counseled her to save her, or to provide intensive care support for her baby, and look where she is now. And so this proud patient of mine is now finishing high school, and it's done well. And so I think, I always remember the lesson learned from that, and I never ever forget that, is the gravity of the conversation. Even though, so I had that slide to say that this is business as usual for us, because, okay, we could have seen 3 of these ladies a day. But kind of remember that these are conversation probably in the worst day of their lives, and it's important that they will remember every word that is said. And so tread carefully, say things carefully, and really try to understand where they're coming from. And so it's never a one-sided conversation. It is important to get their perspective as much as give your own perspective. And so those are the lessons learned.
I love that you were even talking about sitting down and not crossing your arms. And because, often when we have these difficult conversations, and if the physician themselves is uncomfortable having to share difficult information, you sometimes just go into that mode of get in, get out, don't sit down, don't. But how important it is to kind of push through that discomfort for the sake of these conversations that you're talking about.
Absolutely. It doesn't have to be uncomfortable, but it does take experience. And I think these are by no means easy conversations for anyone. So it is actually very important.
And it is so important. I just want to take a minute here and just show you all of the people who were saying thank you and enjoyed your presentation. They're watching from all over the world. There's been a number of people who have said where they're watching from. And just, to me, it just underscores the importance of of you presenting this. And I mean, yeah, so important, as people said, are you going to be sharing this information? Because you did so in such an articulate and respectful way. And so just wanted to take a minute and acknowledge the presentation that you gave, and just the respect and dignity you gave to this often very difficult for everybody consultations. So thank
Absolutely.
you so much for joining us today and for sharing this.
You're welcome.
We have another thank you there as well. And so, yes, I think it's very much appreciated. And for you sharing your wisdom over the years and your knowledge, we greatly appreciate it.
My pleasure. Thank you very much for having me again.
And thank you for joining us and for joining in on the conversation today. It's just a reminder that if you missed part of today's session, or if you want to catch up on any of the Preemie Chat sessions, they are available at CanadianPreemies.org. And you'll find this episode, all back episodes, and many resources and support options available. You'll also be reminded there that CPBF is a charitable organization, and it depends on support in order to continue its important work. Consider how you can support CPBF in its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. Join us here next Friday. We'll be here at 1 p.m. Eastern Standard Time as we talk about when babies are transferred between NICUs and how to ease that transition. Thanks again for joining us. I hope you all have a great weekend.